Hey, welcome everyone. Good evening to those who are joining us for our Seven Starling webinar series, designed to give you, healthcare providers across specialties, pearls to help you feel more confident in supporting your patients with mood and anxiety disorders across the reproductive lifespan. I'm Dr. Nazaneen Homaifar, and I'm a board-certified OB-GYN practicing in Northern Virginia and the medical director at Seven Starling. Seven Starling is a virtual mental health clinic that treats those experiencing anxiety, depression, and trauma throughout fertility challenges, including pregnancy loss and miscarriage, abortion, and postpartum. I'm honored, as always, to be joined by Dr. Crystal Clark. Dr. Clark is an associate professor of psychiatry at the University of Toronto and associate head of research at Women's College Hospital. She has dedicated her career to reproductive psychiatry and the advancement of maternal mental health as a researcher, educator, clinician, and thought leader, and also as an advisor to Seven Starling. We had a lot of interest um, in this webinar, Dr. Clark.
Yes, I see.
And I would love I don't know if there's a chat function available, but I would actually be really interested to kind of get a sense of who's joining us, if you are from the clinical side with OB-GYN, or from the mental health side. I would maybe in the future I'll create a poll. I have to say this is uh, uh, the timing is always tricky with these things, but I think um, I'm really happy to see that there's been so much interest. And I know, Dr. Clark, there's a lot that we're still learning about ADD and ADHD, and it affects about 3% of the female population. But I really want us to focus on how we can prepare our patients. I feel like I see it more than 3%. Um, but
Yeah,
I don't
but
know.
go ahead.
I was going to say, I'd love to delve in. I've kind of divided up these questions about how it might manifest during pregnancy and postpartum, what ADD and ADHD is associated with in pregnancy and postpartum, and management of symptoms, whether it's with behavioral strategies or medication management. And then, of course, hopefully, if we have time, this is a 45-minute webinar instead of our traditional 30 minutes. We can solicit some questions from the group as well. But yeah, Dr. Clark, any thoughts before we get started?
Yeah, so I I would say we have to be careful about TikTok. TikTok, TikTok has
Always,
TikTok and this is not to minimize what people are experiencing because there are definitely people experiencing true ADD and uh challenges in attention. And some of those challenges are related to ADD and some of those are not. But TikTok has definitely been one of the reasons we're seeing such a rise in complaints about ADD and self-diagnosis of
mm,
ADD. And it may not be that there are many more women than the 3% prevalence we are aware of. We don't always have the exact prevalence, so there could be some increase for sure. But there's also a concern that this is really hot right now. Just I'm unable to remember everything when there's not like a lot of consideration around the fact of how many things people are trying to do. So
got it.
many different
Yeah.
ways people's attention is divided and the attempts, especially among women, to multitask and to manage lots of different things at the same time and then feel like, well, I'm not keeping up. It's like some of this is not normal.
I think that's a very fair point, and this isn't something that I had discussed with you earlier, but I guess in general, before we get started, how would you diagnose ADD or ADHD in in our patient population pre-pregnancy?
Yeah, pre-pregnancy, I actually have people fill out a survey to kind of go through some of the things. And it's usually a survey that kind of like look at surveys for depression or anxiety, and it helps to kind of tease out some of the symptoms. And even then, you still have to, a lot of people are going to be like, oh yeah, I, I experience all these things. You have to kind of walk through what's truly a symptom and what may be, like I said, related to being pulled in too many different directions, trying to do too many different things at the same time. So the ASRS one is a self-screener, a self-report scale that anyone can use to check themselves out, and take to their doctor for further discussion and evaluation. And but we're looking at different symptoms like, do you always feel like you have to interrupt someone when they're talking? Are you unable to get tasks done, complete a task? Easily distracted, things like that. And of course, you have to understand this outside of a context of depression or anxiety or other things that could have very similar presentations, and be overlap in presentation, for example. And I just want to highlight a couple of questions on the ASRS, which is the Adult ADHD Self-Report Scale. So some of the things might be
Okay.
like, how often do you have problems remembering appointments or obligations? Is this like a very often issue, or does it, happen sometimes? It happens to many of us sometimes. And we also have to be careful not to overestimate those times where it's happened,
Hmm.
Um, how often do you fidget or squirm with your hands or feet when you have to sit down for a long time? Are you just unable to like sit, still? It's a very fidgety person. And some of that's that hyperactivity, right? And how often do you
Hmm.
make certain mistakes when you have to work on a boring or difficult project? Are you someone who, yeah, the mistakes are abundant because it's not something you're interested in. You have a really hard time focusing your attention. So these are just kind of some of the questions that this screener has, by highlighting some of the symptoms, and it's really having symptoms in a couple of different categories in terms of if it's just ADD, or these are attention symptoms. If it's ADHD, attention and hyperactivity, but usually people have several symptoms and not just a couple.
And so it sounds like, just based on what you're telling me and with the validation of the ASRS one, that
Mhm.
someone could bring these results to their primary care provider, potentially even an OB-GYN,
Mhm.
and let them and make the diagnosis through that. I don't know that the OB-GYN would feel comfortable with the medical management, but
Yeah. Yeah, I wouldn't say make the diagnosis, but at least it would highlight, okay, you know, if they're pan positive, then it highlights, okay, well, maybe this is worth further assessment. The a
yeah.
assessment for ADHD is typically a 4 hour or longer neuropsychological assessment, usually done by a psychologist, to make
Okay.
that diagnosis. So it's not typically going to happen in the family practitioner's office or the OB-GYN's office, or even your general psychiatrist's office. Now, that doesn't mean a psychiatrist might not choose to, feel like they are comfortable with making the diagnosis and starting medication, but a typical assessment of it, evaluation for it, is done by a psychologist in a very thorough, intensive neuropsychological evaluation.
This is helpful for me to know because I think I'll be a little bit more pointed when I ask my patients about a
Mhm.
history. If I
Yes,
ask them specifically about ADD and ADHD, to be more specific and say, have you had the formal testing with the four
yes,
hour test with the
yeah,
psychologist? Thank you
yeah,
for
yeah,
clarifying that.
yeah. Absolutely. And people know if they've had it. Like because
Right.
it's a very long assessment.
I can
Otherwise, they've
imagine.
typically been diagnosed by a psychologist as a kid, in
Okay.
school. And the best history is of someone who had all of these things going on in school at some point, even if it wasn't very early on, by the time of college, it usually is something that, even for the highest functioning person who's able to find coping skills around it, by the time they get to college or grad school, it's usually hard for them to keep up with those types of coping skills. And, they will start to have challenges that they can describe as well.
How can ADD and ADHD symptoms change during pregnancy and postpartum?
Yeah. So we do have, just like depression and anxiety, it can worsen. There can be some more difficulty with attention And usually I'm seeing more difficulty with attention, not so much for hyperactivity. So
Mm.
difficulty focusing, being more distracted, just, not remembering things as well. And sometimes that's related to number one, sometimes people stop their medication. And not saying people shouldn't, it's a personal choice, but if medication is stopped or doses are reduced, we see that for sure. Um, Often, if people are continuing their medication, if they were treated before, that the worsening is less, if any at all. They continue treatment just like they would for anything else.
And then do you know, are there any new symptoms that can emerge, or is it that existing symptoms can worsen or improve? And what I mean by that is like when patients get pregnant and they have a history of migraines, the general rule is a third of you will get worse, a third of you will be the same,
Mhm.
well, the migraine frequency will be the same, and a third migraine frequency will decrease. So, do you offer any guidance for patients who have ADD, ADHD about
Yeah, we
what to
we
expect
don't
with their
know
symptoms?
to that degree. Like, migraines is very well understood in that regard, and we don't understand in terms of ADHD as clearly, as definitively, like, okay, who's going to worsen and why. But we do know that estrogen
Hmm.
and progesterone is, impacting cerebral activity, and that someone who is already predispositioned to have attention deficit challenges, that yes, those rising levels of estrogen and progesterone can impact that further.
And that was going to be my next question. Do we have any specifics about those hormonal changes? Like, given that we see a drop in the estrogen immediately postpartum, is there a difference in how someone might be impacted in their executive functioning, their attention, their mood,
Mhm.
prenatally versus postpartum?
Yeah, so we're going to expect postpartum it to return to normal. How quick, not clear, but it should return to normal fairly quick after that estrogen and progesterone levels have dropped so that they're not impacting the neurotransmitters in the brain to the same degree. But of course, it's hard to say how much it has
Hmm.
improved because now you have a newborn and your attention is divided, and some are feeling
That's
like they
true.
have mommy brain. And mommy
Hmm.
brain, I was actually just doing recently at a talk on a panel talking about mommy brain and the cognitive changes as it relates to hormonal fluctuations. And what we were talking about is the fact that there's no real proof that, mommy brain is a real thing, although I think the women who feel like they're experiencing it might say, no, it's real. But what some scientists have shown is that it's actually a shift in your attention towards certain things. So, for instance, taking care of the baby. So more of your attention is going to go toward, like, your brain is wired to be, protective,
Hmm.
and for your attention and certain things to shift so that you are more aware of things related to the child, safety, things like that, for example. And so it's not that you've lost the ability to think or pay attention. It's just that what your brain is geared to pay attention to has shifted. And,
Hmm.
and that may last for years as you're taking care of an infant. But when they actually do testing on memory and stuff, there's no significant change such that someone has lost memory capacity or brain function or anything like that.
That's a helpful framework, I think, just remembering that the attention is being shifted to something else rather than on yourself. I want to remember that for next time I talk about it with a patient.
Yes.
What do we know about ADD and ADHD and its association with pregnancy outcomes?
Yes. So, I tell everyone that it really comes down to when we're thinking about pregnancy outcomes and treatment and all of this, it's really about how debilitating the illness is for someone. So anything that's debilitating for the pregnant woman has a potential risk of the the pregnancy and the infant. And the reason being is because it's the stress of it, right? Some who have severe ADHD, they're going to be extremely anxious if it's not treated well, or if the meds aren't adjusted if they need that during pregnancy. It becomes very debilitating. The more debilitated they are, the more anxious they are, the more anxious, the more stress, so it's just this very
Never
stressful
ending.
time, right? And it's never ending. And so when that happens, yes, that is not good for the pregnancy. And in those cases, we're talking about, well, is it worth staying on these medications or not? And usually in a case like that, yeah, it's the benefits are definitely going to justify the risks, the benefits of the treatment will justify the risks, basically. So I think about it like that. It definitely can be risky for pregnant patients if it is debilitating. Now, there are some people who are like, I can make it without it. My job, I can still do my
Hmm.
job, still function. It's not ideal, but I'm okay. And for those people, it's perfectly fine to stop their medication or just work with coping strategies to focus, to pay attention, and to make it through pregnancy. But it's not a one size fits all. It definitely differs from patient to patient.
Do we find, I mean, I think I had read somewhere that undiagnosed and well, actually, this goes into my next question. Is there a higher risk of perinatal mood and anxiety disorders, such as depression and anxiety, or postpartum depression, in patients with ADD or ADHD?
Yes, I do not know specifically if there's a higher prevalence if you have ADHD. Assuming it's treated and everything, I'm not aware of a higher prevalence, yeah, of
I
depression or
think
anxiety.
I know I've seen a few studies recently. I know I've highlighted them in the newsletter that show like untreated ADD and
Mhm.
ADHD is associated with higher rates of perinatal mood and anxiety disorder.
Yeah,
And
untreated, yes.
and I think that goes hand in hand with what you were saying earlier, that
Yeah,
if you're not feeling good about where you are, that is going to predispose you
yeah,
to to other to other conditions in pregnancy. Are there any
yeah,
specific risk factors that we should be more aware of when we're caring for
yeah.
pregnant and postpartum patients?
Yeah. And just to go back to what we're saying before the risk factors, yes, absolutely. Any untreated condition in perinatal period is going to put you at risk for other conditions. So especially ADHD, again, the anxiety, prolonged anxiety leads to depression, and so on and so forth. So it becomes a snowball, but there's a very specific trajectory here. This ADHD untreated, anxiety due to the ADHD untreated, and then depression due to high levels of anxiety. So that's pretty common. But does someone just by nature of having ADHD have a more likelihood of having depression and anxiety in general? I don't know if that's the case, and I would have to look up that data to be for sure. In terms
Thank you.
of,
Yeah.
yeah, so I just want to be clear so
No,
that
and it's
people won't
helpful.
assume. Yeah. Go
Treated
ahead.
ADHD, good outcomes.
Come here.
As far as we know,
Come here.
no increased.
Come here.
I'm just going to mute
Come on.
everyone
You're getting in
else.
timeout.
Um, I know, and this just speaks to like how much we're all trying to juggle all at once, trying to learn while we're also managing our children. It's our brains are working at like 100x all the time. Um, but want to clarify. So, treated ADHD, we do not see an increased risk of perinatal mood and anxiety disorders by association, but untreated,
Yeah.
we do have that predisposition.
Yeah.
Um, did you have any specific risk factors that you
Yeah. Yeah, so there are risk factors. There are some studies showing risk factors, and I would say, there's still more data or more research needed to understand. But when we think about perinatal health problems, complications, those are risk factors. Not clear on the mechanism as to why, but
Mm,
it's consistent with most mental health conditions. Like if there are complications, obstetrical complications, then it tends to increase the risk for the illness worsening or onsetting. Maternal smoking in pregnancy is also a risk factor, although we encourage people not to smoke. And so,
yeah.
yes, and of course, any history of having ADHD or having a history of difficulty paying attention, hyperactivity. Like I said, some people go undiagnosed, and depending on what their demands are in life and what type of work they do, they can make it, for a good long time without being diagnosed and managed and cope.
Mhm.
But that history being there is definitely a high risk factor.
And you reminded me of something that you and I have discussed over the course of many webinars, and I know some people are joining us for the first time, but the importance, especially if you're one of the OB-GYNs or CNMs on this call, the importance of screening at that first visit. So while you're going through that patient's history, to get a sense of, are they at increased risk of gestational diabetes or
Mhm.
preeclampsia? Also
Yeah.
sticking in a very purposeful question. Do you have any history of any mood and anxiety disorders or anything
Yeah.
like bipolar or ADD, ADHD? I try
Yes.
and be very, and truly, Dr. Clark, if it wasn't for all the research you've done on bipolar, I don't know that I would have called that out. Um,
Yes.
but I think it's been very revealing because people they fill out the patient questionnaire forms and they don't write anything, that for
Hmm.
them, they have no history. And then you dig a little deeper. Um, and people might say, oh, yeah, I had a history of anxiety in college. Um, and
Hmm.
it's just really important. It has helped me flag individuals that I don't think I would have flagged otherwise.
Yeah. Yeah.
So
Good.
just remembering, I think one thing that we hope everyone will take away is the importance of just asking the question at the beginning so that we can help set our patients up for success as the
Yeah.
pregnancy continues. Let's kind of talk about the behavioral strategies for management of ADD and ADHD. What coping strategies or behavior changes are most helpful for managing ADD, ADHD symptoms during pregnancy and postpartum?
Yeah. So I'm also gonna pull up a maybe I can put in a chat for everyone
Please.
or something.
Do you want to
Um
share it? I don't know how many
yeah,
people are.
a book that I give a lot of patients, workbook or a book they can read because it's, really I recommend people to therapists. You can even do occupational therapy for this. Some of this is affecting executive function, and there are lots of tips that I won't pretend to be the person who has the expertise in all the executive function activities that patients are engaged in to help them cope. But I'm putting in the chat. So scattered how attention deficit disorder originates and what you can do about it. And they have there's some workbooks and things like that that go along with it. But some of it is some just to give some examples, something as simple as not multitasking, you know, forcing uh sitting down, setting a time to do one activity, limiting that time. Yeah, so I think it's what is it, the tomato, the pomodoro, the timer,
The 25-minute timer.
yeah, the 25-minute timer, and using tools like that sometimes are recommended as a way to kind of get you to stay on task and focused and for a short period of time and not trying to worry about tackling what I say the elephants, but trying to break off pieces a little bit at a time so that you can maintain focus. So that's like an example of something someone might be encouraged to do or to try. Again, it's going to depend on that person and the severity of their symptoms and and
Mhm.
and how easy it is for them to do some of these activities and whether they're medicated or not medicated, things like that.
Are there you mentioned occupational therapy. Where do you go to get assistance with more executive functioning?
Yeah. So at a hospital, usually there's plenty of occupational therapists. Usually if someone is working in an academic center with a psychologist, they would often they can equip them with these tools, but they can also refer them to occupational therapists.
Okay. Oh, I didn't realize so
Mhm.
the occupational therapists are going to be the ones working on that executive functioning. There isn't.
they can. Psychologists can do it
Mhm.
as well, but it depends on the program and what the issue is, but occupational therapists can be another resource.
Got it. I know you mentioned Pomodoro method and this workbook. I didn't realize Dr. Mate wrote one of the premier books on ADD. I thought he was all about like trauma, and I've seen a
Yeah.
bunch of his clips there. Are there any other mindfulness practices that you might recommend?
Uh, so I would definitely say that, although mindfulness helps to some degree for everyone, I wouldn't say it's enough to, you know, improve, or how to put it. In the moment, I think it's a little bit more than mindfulness. It's really like trying to focus in and cut out distractions. So, you know,
Hmm.
someone with ADHD may not be best suited in the coffee shop, and things
Hmm.
like that. I think, um, which is a little different than mindfulness, is creating a space to not be easily distracted. Although mindfulness can help to maybe, okay, try to tune out, zone in, but in a different way than we typically think of mindfulness. I see
Sounds
some,
good.
yeah,
Yeah, some questions, but
yeah,
let's move on to the medication management because I know there's going to be a lot of questions about that. How
yeah.
should patients improve?
I'm
Mhm.
just sorry. I'm just putting in another book. It's also,
Okay,
yes. These are all on Amazon,
thank you.
not endorsing Amazon, just giving the book because it's easy to get to. People can
Thank
choose
you.
whether or not they want to buy it from me.
How should patients and providers approach the decision about continuing or pausing ADD and ADHD medications like Vyvanse and Adderall during
Yeah,
pregnancy?
well, I definitely think we have to recognize that the data is limited, right? For for all of the stimulants, the best data we have is on amphetamine-based or derived stimulants such as Adderall, Ritalin. So that's the best data we have. And Vyvanse, we don't know. We don't know about
Okay.
Vyvanse, Strattera, Concerta. They're newer, they're less studied. So it really is coming down to, like I was saying, okay, if you have a patient that's been taking Vyvanse and it's been the one thing that works for them, the Adderall was too much or it's caused them not to sleep, or, they've had, maybe have tried some other things that didn't work as well. But Vyvanse has been what's helped them, and without it, they are not functional. Then you're more so, it's a risk discussion about, okay, what's the risk of us stopping this medication and how that impairs you and how that might lead to you being anxious and getting depressed and so on and so forth versus continuing this medication that we really don't know a lot about and what risks it may
Hmm.
hold or not. And so often the decision for someone who could be debilitated by stopping their medication is to continue it, because we feel that it's, kind of like we always say, put the mask on yourself first. And if mom is healthy, then baby will likely be healthy too. Um, and we approach it that way. But if someone comes to me early enough and is,
Hmm.
pregnancy planning, I'll say, let's try stopping it. Let's see what happens. Do you know what happens? Maybe they don't. And let's see how hard it is for you to, function without this medication. Can you get a therapist or occupational therapist to help you develop some strategies? And will that be enough? Of course, there's always a challenge. People often come in by the time if they are pre-pregnancy planning, they often are not trying to wait, 6 months to do all this or whatever. They're ready to go
Hmm.
now. And so that can, it depends on the patient and how much they want to explore what it means to be without the medication. But I do support patients in continuing their medication. Of course, counseling them that, it's a lot that we still don't know. And if there's a way to be off of the medications, and, I support them in doing that as well.
So what I'm hearing and a takeaway from me based on what you're saying is because I do preconception visits all the time. You might
Mhm.
not be doing them, but I get to see these patients. So when I identify patients who are on medications, um, I think I've leaned in more on we do have some, we know that if someone needs the medications, in general, it is safe for them to be on something like Adderall. But I think what I'm learning too is to say you might want to check in with your psychiatrist and
Mhm.
see if there would be an opportunity to decrease your dose or come off of it. We want you
Hmm.
to feel supported in the pregnancy if you
Yeah,
need medication, but you have the benefit of time right now to decide if this is something that you can come off of.
absolutely. Absolutely. I always want to give people that opportunity, especially in things we know we need more research in, so that they feel also very much clear on why they've chosen to stay on the medication. Some people already know, or why they chose to stop the medication. And if someone stops the medication prior to pregnancy and feels like they're completely debilitated, then they feel more empowered. Like, I know I needed to do this because I would not
Hmm.
have been functional versus, um, well, I mean, maybe I could stop, maybe I couldn't, I don't know, but they proceed, and the first thing that goes wrong, they're like, I knew I should have stopped the medication. I never tried to stop it. There's a lot of guilt and
Hmm.
self-blame, um, which may happen anyway, but more so because they weren't sure that they needed the medication. So I want to always empower women to know that, yeah, but let's explore. I want you to have a clear reason as to why you've made this choice, and I want to help you make the choice that is best for you.
I think you kind of answered this already, but like if a patient chooses to stop the medication during pregnancy, when might they consider restarting it?
Yes, great question. So breastfeeding, then we'll get into breastfeeding. So it depends on um, breastfeeding and concerns there. So you might immediately start at postpartum, and for some people, that is going to be extremely important because now we have the demands of the newborn. For some, they find that they're good because they're not working. And their focus is only on the baby, and they feel like, okay, I'm not being pulled in too many directions right now. But that's
Hmm.
very much individual as well. If you have a mother of three or four, that might be hard, to not be on the
Hmm.
medication. Um, Someone who has to go back to work pretty quickly might find it more difficult to not be on their medication. So it can be started immediately postpartum, or when the person goes back to work, or when they feel like they need more attention. Some patients of mine only feel like they need it for certain days during the week. When
Is it effective in that manner?
Yeah, yeah, it is, and
Okay.
they and they might take it just those couple of days, and they don't take it on the weekends or things like that, and that it definitely works in that manner as well. But when they go back to work, they might feel like, okay, no, I need my full dose, my full,
Hmm.
every day of the week, and that's fine too.
So, for example, like I've had patients who are still working in highly stressful situations who aren't on medications during their pregnancy, but could I tell them, it might be that if you have a project coming up that you're really worried about, you could take it for a short time while you finish that
Mhm.
project. Would that be
Mhm.
almost like spot treatment? People can do that and maybe not
Yeah,
feel I hope no one feels judged or bad about
yeah,
taking the medication, but at least feel like, okay, at least I'm minimizing how much we're using
yeah,
it in the pregnancy. Okay.
absolutely. It is. Yeah, I
That's
use
helpful
it
for me to
spot
know.
treatment often, depending on the needs of the patient, and so that they
Okay.
feel like they don't have to, like they're not confined to taking this all the time, and maybe they
Hmm.
don't want to take it all the time. I encourage there to be. It's better to use like for a period of time or for a few days at a time than to be, all over the place with the use. Um,
Hmm.
but yeah, for a project, maybe it's for the month, or like I said, maybe it's just the week and not the weekends. Um, that works
Good
well
to
for
know.
many.
You mentioned breastfeeding. What should we know about being on a medication like Adderall and
Yeah,
breastfeeding?
and I'm going to speak about breastfeeding. Well, I just want to quickly, and I'm watching the time. We're already over,
Yeah, I know.
almost
We
over.
started a few minutes late, so if you have a
Yeah.
few minutes. No,
Okay.
no, this one was 45 minutes. We
Yeah.
made this from 5 to 5:45, but yes,
Yeah, yeah, yeah. No, I was just thinking we're already almost at 5:45, but I wanted to just
yeah.
make sure everyone knows that at least the amphetamine-based ones are not um, associated with any congenital malformations, but there are concerns like poor growth and small for gestational age babies, things like that that are definitely more linked to um, amphetamines. And again, we don't know much about Vyvanse and some of the newer agents. There is transfer in the breast milk. And of course, some of the things I tell my patient is, okay, well, let's see. Is the baby going to be, now the baby can't sleep because there have stimulant effects due to the exposure. We have to watch and monitor for the child, but in a healthy, full-term baby, I do support my patients in breastfeeding. There's no significant adverse effects that we know of in terms of neurodevelopment, which is one of our major concerns in terms of social, emotional, and cognitive development. But could there be some concerns as the baby get more jittery, more hyperactive, or just more stimulated, less sleep, things like that are worth looking
Hmm.
out for and monitoring for.
Good to know. So, term healthy baby, there shouldn't be any issues. Maybe the pediatrician should be aware that the mom is on
Yeah.
it.
Hmm.
Um, but if you have premature baby, or if there's any other concerns, um,
Yeah.
that would be something to discuss. I'm
Yeah.
seeing some. I know we have two questions in the chat. Let me just. I think you mentioned again. You kind of alluded to this, but what signs or symptoms should patients be monitoring postpartum to know if they should resume medication?
Yeah, the signs and symptoms are really just not being able to complete tasks, which, again, I recognize as postpartum. So it might be that you're pulled in too many directions, but it's one of those like I go to complete a task. It's not because you got distracted because you need to attend to the baby or another child or something like that, but just really can't complete a task regardless of what's going on in the house. That might be a sign, or just having really hard time keeping up with the pediatrician appointments or your own appointments or things like that. Um, but I would say that's probably more evident for someone who already has a history of ADD. I would not say that there's just, to our knowledge, like this um, just increased rate of new onset ADHD postpartum, even though people
Hmm.
might feel like, they're not,
The
their brain
symptoms
is
are.
not, yeah, quite functioning the way it used to. Yeah.
This question just came to me like, is ADD, ADHD impacted by lack of sleep the same way that bipolar would be?
For many, yes, definitely. And it makes sense, right? All of us who, if you have sleep deprivation, you're just not your best self.
Right.
You're not as sharp, as clear, remembering everything as you would if you had had a full night's rest. So definitely it's going to worsen ADHD and ADD symptoms.
We have two questions in the chat. One was, can you talk about non-stimulant medications for ADHD, such as atomoxetine, guanfacine? I don't know if that was meant to be. I'm
Mhm.
seeing more patients on these, as well as patients who are on stimulants and wanting to come off for pregnancy and wondering if these would be helpful for them.
Uh, Again, we don't, atomoxetine, we do not have data on it really. Guaifenesin, we don't really have data on it. So it's, again, just because they're not stimulants doesn't mean like, oh, they're better, because we really don't know. And that's pretty much the best I can say about it. It really comes down to, does that patient need to take them? Is it keeping them from being debilitated? And are they okay with the unknowns in terms of risk? But we don't have much data on.
And then another question is, I've heard some recommendations for ADD, ADHD meds in pregnancy to try to reduce use in the first trimester when the fetus is being developed, and then try to wean down prior to delivery. Is this accurate? What would you recommend?
Yeah. So we are not aware of any related or associated congenital malformations. Again, with those there are stimulants, amphetamine based, based on the data we have thus far. It's more so these other things like poor growth that, we're more concerned about. Might there be cardiac anomalies? So some of that first trimester, avoiding first trimester is thinking about heart and other, just ensuring that there's no congenital issues or malformations of organs. And that's if the person can make it through the first trimester, that's definitely can be helpful in terms of just ensuring that there's no unknown poor outcomes due to exposure that we just, like I said, we just don't know about yet. So I think that's fine. If they, again, it comes back to the patient though, can they function? First trimester, a lot of people are still very much working, and that might be disastrous for them. So, would I take someone off of an amphetamine during the first trimester? No, I mean, we just don't have any data that would suggest that they need to come off of it. Might take them off of Vyvanse or atomoxetine or some of these other ones that we have less data on. It would really come down to what we know about their needs and how that will impact their life.
Any other questions before we wrap up? And while I'm waiting for those to come in the chat, I did put in a great review that was um, in the American Journal of Obstetrics and Gynecology, AJOG, about ADD and ADHD. And to the participant who asked about the non-stimulants, there's a really nice table that summarizes that lack of data. I mean, it provides you dosing and recommendations, but also that this data is scarce. But it's a great table about the various pharmacokinetic pharmacologic
Yeah.
options.
Yeah, speaking and really quickly, I would say like Wellbutrin is one of those non-stimulant. A lot of people don't respond to that. If they really have ADHD and ADD, it's not doing enough. So that's another
Mhm.
issue. So it's not enough to be like, oh, well, let's move you from a stimulant to a non-stimulant in the middle of pregnancy. That actually could make things worse. And to your point about, I'm not sure you're about to make a point about it, but pharmacokinetics, you using that word made me think about, for some people, they'll need higher doses in pregnancy because of the pharmacokinetic
Mm.
changes.
That's good to know. I didn't realize that. I remember vividly one patient wanted me to try half her dose and
Mhm.
see if she was okay with that. But it's important to keep in mind that it's okay if some patients actually need to be using
Yeah.
more.
Yeah, a lot of patients want to go half because they're trying to reduce exposure. And so they want to see how little they can get away with. And I'm fine to support them in that too, long as as long as they're not increasing anxiety and putting themselves at risk for depression.
Mhm.
It's fine to support that. But some people who really are debilitated without their medication will find that symptoms are worsening as they progress in pregnancy and they may need higher doses.
Awesome. Dr. Clark, what's one piece of advice? You've given us many pearls here, but one piece of advice you would give providers caring for patients with ADD and ADHD in pregnancy?
Yeah, personalize the care, meet them where they're at and let them know that there's no shame in needing to continue the medication. There's no shame in going without it. Like they're support them in doing what's going to be best for them because that's going to be best for the pregnancy.
Awesome. And I think for me, the value of checking in at that preconception visit, if you have that opportunity, understanding that this was something new that I learned that you can do spot treatment in pregnancy if someone wants to be off, um, and then um, also just how to think about restarting the medication. And yes, you put in the mother to baby. That's one of my favorite um, resources for medication safety. And it also goes through like cosmetic safety and what to use for
Yes.
a cough so you don't have to answer all of those phone calls. But
Yes.
this fact sheet is available for amphetamines. It's a great resource, especially at the preconception visit. So thank you, Dr. Clark.
Right.
To the providers who joined us today, we hope you found this session engaging and informative. A reminder that we are serving several states and are proud to announce that we now accept Medicaid in Maryland and North Carolina, in addition to our recent launch in Virginia. Also, it's Mental Health Month, so happy Mental Health Month. Probably should have started with that.
Yeah.
Um, we are committed to providing the full spectrum of women's mental health care at Seven Starling and would love your support and your patience. So you can check out our website if you want to learn more about how we may help you in your own practice. If you ever have any uh, uh, ideas for webinars that you want to hear about, I loved that there was so much engagement with this one, but you're welcome to send me an email at Nazaneen at sevenstarling.com. We'd love to leave you all with little pearls at each of these webinars that you'll integrate into your own practice. So, Dr. Clark, thank you so much. Sorry for the late start, but I look forward to the next time.
I do, as always, as well. Thanks for having me, Dr. Homaifar. And yeah, let's do it again soon.
Sounds great. Have a good one.
All
Bye.
right. Bye.